of the public. Now looking next, it's declarations of interest. Any changes to declarations of interest or any updates? No. Okay. Sounds a bit slow scrolling down. So then it's on to minutes of the last meeting on the 16th of June. Should we go through for accuracy? Page 1, 2, 3, 4, 5, 6, 7, 8, 9, and 10 just for signing. Anything anyone wants to raise up, Hessian?
Just a point of clarification, really. On page 7, under performance, second paragraph, it talks about the average attendances in A&E. It says average is currently at 110 daily attendances, although the 5 conversion rate is still comparable. Is that a typo? Which I didn't really understand the term 5 in that context. Are we talking about bands 3 and 5, or are we just talking about conversion rate in general?
I think it was. So Eric, it's Victoria. I think it was conversion rate in general, so I think it is a typo, Hesh.
Okay. Thank you.
Thanks, Victoria. Now on to action log. Stroke performance. We've had this separately via SDC, haven't we, Victoria?
We have. So we've also invited clinical colleagues to come to a future development session of a governing body. So that's been arranged, and we've also separately had some information through that I've sent through to SDC for their information as an assurance in the meantime.
Thank you, Victoria. Next few items are deferred. COVID's on the agenda, finances on the agenda, complete. Stroke again. Performance will come up later. And the rest of the things look complete. If that's all right. Next it's on to Chair's report.
Sorry, Eric, can I just ask one question about stroke?
Of course.
Thank you. Again, thank you, Victoria, for the data. That was quite helpful. So I am more reassured than what I was when I first asked the question. One thing that I'd probably want to see from a governing body perspective and SDC perspective is more Bassetlaw specific data. So I know the numbers are small. The data is more focused on DBHFT as a single provider, but they did make some references in terms of transport and Bassetlaw specific patients. It's reassuring to see whether that their outcome measures, readmissions and mortality rates are relatively low in comparison to other sort of peers, if you like. But even if it means that we've got 2 patients out of 100 going in, if there's 100 patients going into DBHFT and 2 of those are Bassetlaw specific patients and they have a poor outcome, from a percentage perspective, that'll be quite good. But from a Bassetlaw perspective, we need to understand why that is the case. So when Dr. Anderton, I think, is that right? When he does come across, it'll be helpful for him to bring some Bassetlaw specific data and things that we can hopefully do to try and improve outcomes for Bassetlaw specific patients as well, especially transport, because I think that seems to be one of the big triggers.
Yeah, yes, it was, Hesh. The late presentation was one of the things that's been cited. And indeed, he's already committed to provide a bit more of a Bassetlaw focus to the data when he comes and does the presentation. So that is the expectation.
Thank you, Victoria. Now on to Chair's.
Eric, sorry, I've got my hand up as well.
Oh, sorry.
It's all right. Just on one of the other actions, the command and control, Hayley was doing a self-assessment at Doncaster on the governance side of things. I just wondered how that had progressed or whether it's actually been overtaken by events.
It's probably a bit of both, Sue, to be honest. Now, I know we did look at it, Cheryl, Michelle and I, and we did undertake that assessment, but to be honest, we've not taken it anywhere in Bassetlaw. It did go to the exec committee in Doncaster, but we probably, you're absolutely right, we probably just need to ensure we've ticked that box. But the assessment was undertaken to make sure that everything was in place that should have been.
Thanks.
Okay. Thanks, Hayley. Thanks. So apologies, I can't see any raised hands today. I'm actually looking at my toolbar. My raised hand has disappeared. So if people do have questions, could they actually please physically raise their hands? I do apologise, but I had some Teams problems this morning. I had to reinstall it.
Eric, you put the participants list down the side. Would that help you?
It looks like Eric's in as a guest, and I assume that must have some issue with.
To then, will he?
Yeah.
We'll flag up Eric if somebody has to have that.
Okay, thank you. Apologies. Yeah, I did have to enter it as a guest as well. Right, go on to Chair's report. This is for noting again issues around COVID, which just seem to sort of develop on a sort of day-by-day basis. Again, being incredibly pleased how our local system has responded to COVID, how the partnerships have worked incredibly well together, which I'm sure will be gone into separately, but it just re-emphasises the importance of having strong place-based leadership within Bassetlaw. With whatever changes may or may not come in the future, we need to ensure that we maintain. We're having ongoing conversations with DBH, FT, largely Victoria and I on a Monday, touching on performance, touching on polling ranges, etc. But there are issues, and I'm sure Victoria will go into a lot more depth around performance, particularly around 31 and 62 day cancer targets. Primary care has remained incredibly resilient in Bassetlaw. We've had no practices closing down, so everything that practices are put in place over the COVID period, over the initial COVID period, seems to have worked incredibly well. I'm just looking and waiting to actually see what's going to come first, a vaccine from Oxford or a second spike locally. Hopefully the vaccine, and we won't have any second spikes over winter. I think that's roughly all I want to say. Anyone got any comments? So, thank you. So over to Idris for Chief Officer's report.
Thank you, Eric. I'm conscious that there's a COVID update later on in the agenda, and obviously the first part of the report touches on a number of the things that Eric has just mentioned. So I'll just draw out the later part of my report, which is with regard to the transition to what many called the new normal. Not quite sure what the new normal exactly will be, but we need to obviously adapt to the fact that COVID will remain sort of endemic within society for potentially quite a considerable length of time. But also we've got needs that have been created either during and as a consequence of COVID indirectly. So, for example, those that have had to self-isolate, children not being able to go to school and socialise as normal. Some people have exercised more, others less. So there's different consequences, different people. But also there's the potential direct consequence of worklessness as the economy is sort of hit and tries to recover, and issues of supporting and continuing to support those that are most vulnerable, whether they be shielded patients or patients with mental health issues which have been exacerbated during the COVID crisis. So there is quite a wide-ranging task ahead of us that we will continue to work with partners on, in the same way that we have done during the COVID crisis to a large extent. So we have adopted different ways of working. We, I think, are far more streamlined, action-focused, less bureaucratic than we were before. That won't replace good governance, such as we're seeing as part of our governing body, and there will be things that we'll be putting back in place. But there will also be sort of more rapid work carried out in the future on the sort of areas that I've mentioned, and part of that will be done through the Integrated Care Partnership, which I think has served us well in terms of the relationships that we have with our partners and how quickly we were able to come together right at the beginning of the COVID crisis. And I think when we look back in time, we will, I'm sure, see and recognise that our response to COVID was a few weeks ahead. So before we went as a country into lockdown, we'd already put in place a number of changes, and including a meeting that we had a couple of weeks before that with local leaders that, for example, meant that the community and voluntary sector started to gear themselves up several weeks ahead of many others in parts of the country. So I think that's served as well, and sort of echoed what Eric has said. And I think now we've got quite a long, hard road ahead of us, and the work will continue. So I'm happy to answer any sort of questions, but like I say, later on in the agenda, I will give a more detailed COVID update about where we are.
Okay. Thank you, Idris. Any questions for Idris? Okay, thank you. Morning, Nicola. On to Nicola for quality of patient safety update.
My paper's probably slightly less COVID for once in the last few months. So first thing to note is the NHS complaints process. I did inform governing body a few months ago that it was paused. We've now been advised that as from July, well, the end of July, we will be back to normal complaints response mode. We are already seeing the Ombudsman making contact back with us around a complaint that we've got with the Ombudsman. So I think they're resuming into their normal business. So it's just to be mindful, obviously, that we're back into our statutory functions around complaints. Second in the paper is information about the ICON project, which Bassetlaw CCG is rolling out in conjunction with our partners in South Yorkshire. The ICON project is around normalising babies crying, so supporting parents to understand that sometimes your baby does cry for no reason, and that's healthy and okay. And the work that we're doing is in conjunction with, obviously you don't shake the baby's work that we've done previously. It's really positive, this work, and the trust are really supportive around rolling this out, and we're working with our Nottinghamshire partners as well, because it's not been rolled out yet in East Midlands, and they're looking at actually how they can go alongside us and roll it out themselves. So something really, really positive. Just to note that we've now got an associate designated clinical officer for SEND that's been appointed across Nottinghamshire, so that will help with our SEND referrals and assessments. We've seen over COVID a reduction applying for EHCP funding, so we're anticipating, as people go back into school, particularly in September, an increase in children being identified as potentially having requirements that would meet the SEND criteria. So obviously that role supports all those assessments and working with our partners, so we're really pleased about that. Couple of national appointments, so we've now got a regional chief midwife for the north. Again, first time we've had a regional chief midwife, so that will help raise the bar around maternity and obstetric care through the North and South Yorkshire and Bassetlaw, and will help to drive the LMS agenda forward. We have noticed during COVID that the LMS work has probably been put on hold really and been difficult to continue achieving, so continuity of carer. Some of the teams have had to work differently, so that what we were achieving is probably taken a couple of steps back, so that will help to drive that forward and ensure that we're working into the national wider picture with the Chief Midwife. And also the second appointment, there's the new Domestic Abuse Commissioner for England and Wales. Again, really positive, gives some national leadership around domestic abuse. And we know through COVID, we've seen increased levels of domestic abuse, and particularly we'll probably see more as we come out of lockdown and people come forward for help and support. So that will help work into our Nottinghamshire group. Personal health budgets, we continue to work above trajectory. And obviously we've got targets for this year, but we're still seeing people applying for personal health budgets, and we're working through with them how they can get back to accessing some of the services that they previously funded for, because obviously people, particularly with the physiotherapy, have not been able to have their face-to-face support. So we're looking at that and supporting people through. Continuing healthcare, obviously, as from the previous governing body, you've been aware that actually everybody that comes through as supported discharge is fully funded by health as part of the discharge arrangement from COVID. We're starting now to see some indication that it'll probably be September when we have to return to some sort of normalised continuing health assessment process. What that looks like and the detail of that is not quite clear. So we don't know whether it'll just go back to what's defined in the policy, or whether there'll be some bridge between what we've been doing and the policy requirements while we get all the assessments done. And as we've indicated in the report, we've got about 125 individuals that may need a DST or some sort of assessment. So we're doing some work to try and understand those individuals, and we've worked really closely with our partners in Notts Healthcare Trust who do our assessments, and they've got 6 to 8 weeks worth of capacity ready for us to turn the tap on and start doing these assessments. So whilst I think there'll be some tight time scales, I think it's quite achievable for us to be able to do that piece of work, providing there's nothing that comes in left field that we haven't anticipated. So it's just if there's any questions, really. And I know Hesh has got one.
Thank you. Yeah, just PHPs really.
Yeah.
I suppose yourself and myself have seen a lot of remote assessments or remote care via PHPs during the lockdown period and the pandemic. And I wonder whether going forward, taking Idris's point around the new norm, whether we ought to evaluate whether those remote physiotherapy, Pilates, etc. is having the same outcomes as the face-to-face. And therefore, does that have a bearing in terms of future PHP costs? Because if patients can access them remotely and do some more self-care, then overall that hopefully would cost less. So I wonder whether that's happening nationally or locally.
So what I've started to do, Hesh, I looked at something last week that Liz sent me, and I did ask her to go back and ask what they've been doing for the last 3 months, that individual, because obviously it was a review. So how had they been receiving their input? And a couple of them I've recognising they've not had any particular physiotherapy for quite a period of time. I've actually said 4 weeks of sharp intervention and then back to a much more maintenance level, because I think that's the problem. People get their health budget and they get a really good weekly physio or whatever, but actually as you know, they become to a level of maintenance, and we have to perhaps go to fortnightly or monthly physio, because our expectation does have to be that they're doing some of these exercises and things themselves. So yeah. I think Liz is starting to ask that question, what have you been doing, and actually have people really deteriorated when they've not been having this every week?
Yeah, I suppose my question is more about can physiotherapy or Pilates be delivered virtually for most of our patients, and would that have the same outcomes for most of our patients as opposed to hands-on? And if the answer to that is yes, would that be, should that be evaluated to see whether the outcomes are the same, and therefore whether that could be more of Bassetlaw's norm. So most people will access physiotherapy or Pilates remotely unless they've got an exceptional circumstance why they can't. Do you see what I mean? It's just to see whether that's happening.
I suppose we're doing it on an individual basis currently, Hesh, by asking that question. Actually, if they've continued to have it virtually, can that continue to happen? And we know it does work virtually because obviously people it's been provided, but I suppose some people might want some virtual and a little bit of contact, because I suppose with some of the Pilates, particularly if it's a class, there's some social interaction there, isn't there, for individuals? So I suppose some people probably would want a combination of things. So I think we are starting to do that, and I think that's the question we've got to start asking.
Thank you.
Thanks, Nicola. Any further questions for Nicola?
Kumar's got one, I think.
Yeah, thank you. This is a question to all clinicians, really, in terms of domestic abuse. So have you come across people giving information like there's a high risk of domestic abuse? Are you coming across more often in the last few months, or you have not? No. Thank you. Do you all ask in your depression, when you see patients for depression or anxiety, do you routinely ask about domestic abuse? No. I mean, I think Hashin is about to say something. It's just to point out that, as you could see, that the National Domestic Abuse Helpline, it was quite busy, and as a clinicians, apparently we have to ask about 20 times before they say yes that they went through domestic abuse. So it's just whether we have to have a comms to our colleagues that, when you routinely see someone for anxiety and depression, sorry, in the part of Arden's template is clearly asked about domestic abuse and the types of abuse. So lately I have started asking when anyone who rings for anxiety and depression, I go through Arden's template, and quite a significant number of people have said they went through domestic abuse in the past. There isn't anyone who have said that they've gone through abuse in the last few weeks, but they have accepted. It's quite interesting that it may be that we may not be asking more. So it's just to highlight it, and when you send a communication, perhaps we have to say, perhaps use the Arden's template or any other templates when you go through anxiety and depression, because these things could be recorded and we could address that.
I think, Kumar, I suppose the problem is at the moment where people are having the consultation in their own home, the abuser or perpetrator may be in that home listening to the call, because actually a lot of stuff's being done on phones and laptops and iPads and that sort of thing, and the person may be in the house, so they may be reluctant to disclose anything currently, and we've got to be mindful of that, I think, in the current circumstances.
Yeah,
that's not just for the
point, Nicola.
Was that your point?
Because even when they do come to the hospital, if there is domestic abuse going on, you find that the partner is usually with them and they're all overly attentive, and that's what we see in gynae and maternity. So it's very important that we get to speak to the patient separately. But in order to be able to speak to them separately and ask, you've got to have the patient trust you to a certain extent. It's quite difficult at the first consultation to develop that sort of a trust. The midwives are better because they work with the patients over 9 months, so they slowly build up a trust and a relationship. So that's where we see our issues coming, but we've not noted any increase in the recent past.
I think Deepti wanted to come in.
Yeah, what I wanted to say was it's quite a difficult question to ask because you don't know the surroundings, you don't know what's happening. I think what I normally tend to do is how are things at home. It's just a vague question. You just talk about stress and everything, and you just need to have that relationship. If you just ask the question very bluntly without knowing what's happening in the background, the chances this person, because of whatever factors, is not going to see you back again. Because the partner would have been listening to this conversation and they would be discouraging them, because domestic abuse is something that's a completely different beast. There are lots of ways you can abuse somebody. It's not just physical, it's emotional, it's financial, and lots of other things. So we just have to be careful. And I just have an opinion on that. Asking the blunt question when the person is not on their own and when you're not certain can cause more problems than solve.
Kumar, did you want to come back in?
Yes, I mean, I think 2 points really. I think the first one relates to whether they're going through domestic abuse right now. And clearly this is a very valid point Nicola and Deepti raised. They may not say. I think with virtual work consultation now, they can also send email to us. So it gives them a bit of a better, they may able to send emails. So there's a bit of a leeway on that. The second thing is they are accepting that they've gone to the domestic abuse in the past relationship. And previously as a clinicians, we, it's not very commonly asked, but now if you ask, at least they accept actually went through domestic violence in the past, and then you're able to signpost to them. So I think it is quite important that, we still raise them in a very indirect way, or if you're not getting it, perhaps direct, if you are comfortable and you have a good working relation with that patient. Thank you. But that's my thought. I mean, I just wanted to raise it because it's important we ask, because it's staggering when they say that you have to ask 20 times before they accept. So, we don't want to just brush under the carpet. That was the point. And any communication to the GP colleagues, if you all agree, I think, it should be a newsletter or something. We can add this information if everybody agrees with it.
We could perhaps do something at best. Kumar, I could ask Andrew if he could get somebody in to do some an update or something. That might be helpful. Yeah.
Yes, Nicola, I think that's a good point. I think that's how I learned that you have to ask 20 times before they accept. I think that's from a best teaching many years ago. So yeah, it's a good point.
Eric, I think Mike's the last person with his hand up on this one.
Dr. Hall.
Hi. The comments that have been made are all very relevant. I think just an observation, first of all, I think I've been surprised when I've sent and referred people to counselling services, how many times when a report comes back that abuse is mentioned. And it what it reinforces in me is that the consultation with me, because they are sometimes fewer than other people, the question of abuse doesn't arise. As Kumar said, you need multiple presentations to build a relationship and for them to admit there's a problem. So I think often I find that actually referral to counselling services, talking therapies, that's when people, when they build a relationship, are much more able to actually bring this very difficult subject up. So I think higher up the list is always considering and encouraging patients to actually engage with counselling services. I think they sometimes find it difficult sometimes with the GP, but with counselling services. So that's just an observation. The most, and certainly I think the thrust must be making these helplines much more open and available to patients. So wherever they come and see us, and they go to all other health facilities, they see that number. That is, I think, probably more likely to make them themselves. But just an observation.
Thanks, Mike. So, Nicola, will you speak to Andrew about having something at best?
Yeah, and I'll also, I know Sarah does dial into governing body. We'll look about, see if we can get some comms out on to practices, perhaps some laminated sheets with the numbers on and that sort of thing. Again, to put in waiting rooms, that might be helpful. And sometimes places I've seen it is in ladies' toilets. When you go into pubs or restaurants, often they've got things in the toilets, because obviously women tend to go in there on their own. So, if you've got women's toilets in your practice, it might be worth putting a poster up in there as well.
So it was interesting, both Hessian and Mike were nodding when you started talking about ladies' toilets, Nicola.
I get most of my information from men's toilets.
No, it's a good point, because we've got exactly that. We've got all the domestic abuse and domestic violence helpline numbers, and a poster where you can actually tear off the number. Yeah. The poster comes with a series of numbers at the bottom, so we've got all that in our in all of our toilets. It's probably not politically correct to assume that domestic violence only happens to women. It happens to men as well. So so yeah, the numbers are there.
Yeah.
Brilliant. Thank you very much. Thanks for that update, Nicola. We now move on to finance, Hayley.
Okay, thanks for that, Eric. Okay, so you've got the paper as part of your pack, but I'm just going to pull out the main bits and pieces because we're in a very, very different financial environment to what what I've ever seen in my 25 years in the NHS. So I'll just kind of go through where we are, what I know and what I don't know, and the clarity that we're still seeking, and where we currently are finding ourselves. So just some context, and I know I've said this before. So we didn't finalise our financial plan because the contracting round was suspended. So therefore, we've not actually got contracts in place. They are implied. They are on NHS terms and conditions, and that will continue for the rest of the year. Now we've got new financial arrangements put in place. They were directed to us. We've got a month 1 to 4 allocation, and that's April to July 2020. And that was based on month 11 cumulative expenditure in 1920. And that's the basis of our allocation, and that was with some growth, but it didn't include everything, and I'll go into that in a minute. We've and this is the stuff that's coming out certainly in the last couple of days, but there is some further clarity needed. We are now likely to get a further allocation for month 5, definitely. Month 6, we're expecting as well, based on probably the same methodology, but probably refined a little bit in terms of what providers have submitted in terms of further costs, like CNST, for example. And then what we're likely to get is then a 6-month allocation, which will be October to March 2021. But discussions are currently undergoing. There's discussions with the Department of Health, NHS England, and with Treasury in terms of what those allocations will look like. And I think they're obviously proving really difficult because of the uncertainty in terms of the funding envelope. So I'm just going to go down in terms of what we currently know and what's kind of emerging in these next few months. So we've got all NHS providers on block contract payments, and that's directed to us. So that's over a threshold. So we can't pay NHS providers anything more than what's already been directed to us. And that we are being told that will continue now till the end of the financial year. But those block payments may be altered in the next few months, depending on these returns from providers, which will be refined slightly. Primary care payments for the first 4 months, we were told we needed to protect income at the 1920 levels. We got a further letter out, I think it was the 8th of July, 7th, 8th of July, from both Nicky Kanani and Ed Waller, which set out some further arrangements in terms of restarting QOF, restarting DESAs, and also the expectations in locally enhanced services as well. And CCGs essentially being holding general practice to account for those arrangements. Non-NHS providers, we've only paid non-NHS providers if they are continuing to provide services are vital to the pandemic response. And there's two cohorts really. There's the independent sector who are part of the COVID response. That has been a directly negotiated contract between NHS England and those providers. We haven't had anything to do with it. And those arrangements are now likely to continue until we're being told the end of the calendar year. So that's what we're going to be forecasting in terms of our position. It may go longer than that, but we do know that providers and places are being encouraged to utilise that capacity as part of the recovery. Up to now, we've had a retrospective variance adjustment. So the objective up to now, and it will continue, has been to break even. Now, you'll see in the papers for Bassetlaw that we are currently showing a £761,000 deficit. That's not unusual. Every CCG, certainly in South Yorkshire, is showing a deficit position. 424 of that directly relates to COVID expenses, and that is we're submitting on a monthly basis COVID expenses, and we are starting to get those funding adjustments in. The overspend over and above that, as at this time, we haven't yet got that in. There's much more challenges being queried across CCGs, across providers, and there's some real rigour in terms of how they're looking at that. I certainly think for us in Bassetlaw, I don't think there is anything that we've got in our position which is not justified, and therefore I'm really comfortable that that those challenges, you know, will be easily answered, and therefore those funding adjustments will then come. We are forecasting to the end of July, to month 4, £1.3 million. In terms of a deficit position, and that includes a further 600k COVID expenses, and primarily a lot of that COVID with the discharge policy, which at the moment, and Nicola's already made reference to some of this in terms of the assessments, at the moment, as it currently stands, those patients aren't means tested, so the NHS picks that funding up. But there will be a transition. We've not got any dates really just yet, but there will be a transition in terms of how that, how that resets. There's a couple of items which are really obvious in terms of why we are in a deficit position, and it's common across CCGs. So the allocation's not been sufficient in terms of the primary care delegated budget. And so all the primary care networks, you know, the posts that have been set out in the guidance, that's not been given to us in terms of funding. So we are short in terms of primary care delegated funding, but again, that's not uncommon. And also the other area that we haven't got the allocation that we should have is to do with the running costs, the admin, the infrastructure, the organisation. And again, that is common across organisations, because some organisations use some slippage out of running costs to basically fund other things, other programme areas. Now, that's not the case in Bassetlaw. We spend up to the allocation for obvious reasons, in terms of, you know, economies of scale, etc., and it being a smaller CCG. So again, you know, there's just been a blanket approach applied, so that's caused some pressure as well. So then, sorry, I've got some notes that I'm going through. So the things that aren't clear to us are around investment and transformation funding. So that's been a real risk and is continuing to be a real risk. Now, the things that are coming out the last couple of days, have been on a couple of calls, one national and one regional. There is still no clear direction on investment or transformation funding, but it does look very likely now, in terms of the conversations I've had over the last couple of days, as though the allocation is going to system level. And I'll go into that in terms of what the current ask is. We've got no new allocations, we've got no non-recurrent funding streams, but again, I'll go into what we're currently doing, both Michelle and I, in terms of the finance arrangements for the final 6 months. Now, the mental health standard, the EMIS, up to now, there's been no clear guidance in terms of whether we are required to hit that standard. Now, certainly the calls that I was on last Wednesday, Thursday, last week, it is now really clear that we are expected to meet that standard, and we're expected to meet that standard for the full year, bearing in mind, you know, we're already well into month 4. Plus, we haven't got the funds flow either. So what we're expecting, and this came out on the national call, we're expecting some guidance in terms of funds flow, guide us how we can actually meet that standard. So again, you know, the clarity isn't there. We're being told on one hand there's no investment or transformation currently, but on the other hand we're being told that we are required to hit the mental health investment standard. At this point in time, we normally, every financial plan that we do, we hold a contingency. We're not allowed to hold a contingency. So the figures are the figures. You know, we're expected to essentially submit our costs, and quite clearly, it will be a deficit position for the reasons I've articulated. But then we will get top-up funding. We don't have any mitigation anywhere. We're not allowed to hold a contingency. There is lots and lots of scrutiny, as I've said, on the costs that are going into the financial position. And I'm quite comfortable that the costs that we've submitted are reasonable in terms of everything we've done so far. Now, just going on in terms of the arrangements going into the second half of the year. Month 5 and month 6, which is August and September, I've already talked about, we're likely to receive very, very similar in terms of allocations. It might be slightly different in terms of the blocks when providers submit theirs. In terms of the second half of the year, although we're still waiting for this, you know, eagerly anticipated financial framework coming out, and we will get that, we are now, all the CCGs, planning on doing a return. And we think that return is probably likely to be towards the end of August time. Now, that return will include everything that we are forecasting spending so far. It will also include everything that we know about in terms of investment. So, for example, it will be all the delegated primary care, you know, the primary care networks, the posts, the additional posts in there. It will also it will also contain things that we know about, we've already committed to, and we want to, you know, we want to flag that in our system, in our place. So we had quite a detailed conversation yesterday with the other CFOs and deputies across South Yorkshire and Bassetlaw, and what we're trying to do as CCGs is we're trying to hold a really consistent approach in terms of how we approach everything and all our costs, because what we don't want to do, if the allocation does go to a system level, I don't know how it can yet because of the legalities and the legislation, but if it does go to a system level, we want to, as CCGs, we want to be in the best possible position that we don't get picked off as individuals and basically challenged for our costs. And also, we don't want to be trumped because the providers will be doing exactly the same. And as we know, providers will be under some massive pressure to put realistic trajectories in there, and therefore potentially their cost bases may increase. So I think as a group of CFOs yesterday and deputies, what we were saying was we want to give ourselves the best possible chance of making sure that we have got a reasonable assessment of our forecast costs going into the remainder of the year. Now, the issue, we don't know what the financial envelope we will have. Now, all we're going to do as providers and commissioners across South Yorkshire and Bassetlaw ICS footprint is we will put our, forecasts in, and then depending on what the national settlement is, what they negotiate from the government, there may well be conversations in terms of how then we manage that across the system. And there's lots of discussions around principles. How does transformation money work? Is there going to be some kind of top slicing risk share, etc., etc. They're all conversations that are going on, and there's a lot of pushback, as you can imagine, from the the collective directors of finance, across commissioners and